Welcome all the students to Jaipur Surgical Tutorial. This is the new chapter that we are starting today. As some of you know, who have been associated with JST for some time, that we started this online surgical tutorial way back in May 2021. And this is being looked after by my colleague, Dr. Anand Nagar, who is a professor of HPB surgery at Mahatma Gandhi Medical College Hospital with me. We have so far been doing case presentations by you people, which are moderated by faculty, so as to prepare you for your final exit DNB or MCH exam. In between, we have requested you, and I think I want more and more of those presentations, to present operative surgery also, indications, contraindications, preparation, procedure, and complications. Again, you have to prepare and the faculty will moderate. We have had very few faculty lectures because we think that faculty lectures anyway you listen to in many CMEs and conferences, but from time to time, we have faculty lectures, especially the related specialties like anesthesia, critical care, medical oncology, radiotherapy, and all. And recently, we received requests from some of the students that there should be a session on clinical trials also, the established and famous trials which are used in day-to-day clinical practice. So I think that was a very good suggestion, and both Dr. Anand and I discussed, and we've started this new chapter, which we will name Trials and Tribulations. So this is the first volume of that. And the format is that we have asked you people that what are the common trials, what are the trials which you will be asked for in the exam, as well as which will be useful for you in the clinical practice to treat your patients. So although we have given 15 minutes to each presenter, but I would request Dr. Murugappan to be liberal. If the discussion goes on a little longer, it is fine. We should go into the details of each trial. And if we are not able to finish all the 4 trials today, we will carry it over in the next session. Anyway, you people have prepared, and I'm sure Dr. Murugappan will be available. So in today's session, we will be discussing esophagus. Then the next session is already scheduled on pancreas, which Dr. Diksha Kapoor has very kindly agreed to moderate. And I think some of the students have already volunteered, but I would request more and more students to volunteer. You just have to prepare the summary of one trial related to pancreas, which you will be presenting in about 10-15 minutes. And then the faculty will moderate and give some comments. So with that, we can start this session. And I'm very happy to say that the first student who responded is Dr. Nishaathussein Naushad from Tanzania. He has been a regular overseas student of JST. He has even attended the Jaipur Surgical Festival last month in December. And he is a young budding surgeon in Tanzania who is also keen to come to India for further training, and I'm trying to help him get a place for that. And he volunteered to make this presentation on FLOT4 trial, which probably now, as of today, is the most commonly used trial in esophagus. So I just gave the introduction, so please take over. What I said that although we have given 15 minutes for each trial, but be liberal. If the student needs more time, if you need more time to make comments, and in between, if there are questions, then we will extend the time and we will continue this session in another session. So we need not hurry. Let us discuss in detail. Since this is the first time we are doing it, I thought 4 trials, but maybe in future we will include only 2 or 3. Okay, over to you, Mishra.
Good morning, everybody.
So, good morning, everyone. Esophageal cancers as such is an aggressive disease with poor outcomes despite all the advances in the management that we are having as of today. So, as Sir already said, we'll be discussing 4 important trials on this cancer. There are 2 landmark trials which form the basis for the discussion today, and which has shaped the management of esophageal cancer. The first of which is the MAGIC trial, which was done in 2006 from the UK, which looked at the use of perioperative chemotherapy along with surgery versus surgery alone. Majority of this trial patients were gastric cancers. They were all adenocarcinomas. Only 1/4 of this trial participants were GE junction tumors. The issue with this trial was only 42% completed the entire protocol of the trial. Despite this, the use of perioperative chemotherapy provided a 5-year overall survival benefit. That was in the terms of 36% versus 23% in patients who underwent just surgery. So this trial changed the standard of care to perioperative chemotherapy. The second landmark trial, which we should all know about, is the CROSS trial, which was in 2012 from Netherlands, which looked at the use of radiotherapy in the management of these tumors. Again, it included both adenocarcinomas and squamous cell carcinomas of the esophagus. Majority were adenocarcinomas, around 70%. This trial showed that the use of radiation in these cancers resulted in a pathological complete response in terms of to the tune of 30%. The effects were more pronounced in squamous cell carcinoma, which had shown a PCR of around 50%, versus adenocarcinoma, which showed a PCR, a slightly lesser PCR of around 20. However, there was a gross improvement in the overall survival, which was found to be significant from 24 months to 48 months. That is, the overall survival doubled to 48 months. So this established that neoadjuvant chemoradiotherapy is the way to go for management of these tumors. So the four studies we'll be discussing today are based on these two landmark trials. First of which is the FLOT4, which took forward the idea of magic and used perioperative chemotherapy, which is a taxane-based perioperative chemotherapy based on the response of taxane in adjuvant setting in advanced disease. And this we'll follow it up with the new AIIMS trial, which looked at which is the optimal advanced adjuvant therapy, that is whether it is the chemoradiotherapy or the perioperative chemotherapy. We'll follow this with the Checkmate 577 trial, which looked at the role of immunotherapy in the adjuvant setting. And finally, we'll have the SANO trial, which looked at the role of active surveillance in these patients who responded to chemoradiotherapy. So we'll start with FLOT4. Over to Dr. Nishad.
So before Nishad starts, all students, Dr. Murugappan, who is my former fellow from SVPGI Lucknow, he has written a very beautiful review on the role of neoadjuvant and adjuvant therapy in CA esophagus. Please send me a mail, vkkapoor.india@gmail.com. I'll be happy to send you the copy of that article. And don't say thanks to me, say thanks to Dr. Murugappan for that article. Yes, Nishad.
Good morning. I'm Dr. Nishaathussein. I'm going to talk about the FLOT4 trial. I would like to thank Professor Kapoor for the opportunity. And I would like to thank our moderator, Dr. Murugappan, for guiding me throughout the preparation of this presentation. So, FLOT4 trial was published in April of 2019, and it's a multi-center randomized controlled trial, phase 3 trial. Before getting into the details of the trial, a brief introduction. As Sir has mentioned, that there were two landmark trials before this trial, which showed the benefit of perioperative chemotherapy in gastric and gastroesophageal tumors. And the first and the largest being the MAGIC trial, which was published in 2016, which showed a 5-year overall survival benefit of 13%. Followed by the French trial in 2011, which showed a 5-year overall survival benefit of 14%. So this was significant given the nature and the prognosis of the disease, and for which the ECF-ECX regimen in the MAGIC trial become the standard of care. But the prognosis of gastric and gastroesophageal tumors still remained poor, and hence there was a need for further trials with the newer regimens to improve even more. To improve even the survival furthermore than the already established standards. So docetaxel-based chemotherapy, which was used in the FLOT4 trial, was extrapolated from the FLOT, which was used in the FLOT3 trial for metastatic gastric and gastroesophageal junction adenocarcinomas. We showed a significant improvement in terms of regression and survival. And therefore, in the FLOT4 trial, patients are randomly assigned with histologically confirmed locally advanced gastro and gastroesophageal junction adenomas of clinical stage of at least CT2 or node positive or both, which were resectable with no evidence of distant metastasis, and this was compared to the ECF-ECX regimen in the MAGIC trial, which was the standard of care at that time, was compared to float, and the aim of the study was superiority. So float float consists of docetaxel 50 milligram per meter square, which was given on day one with 5-fluorouracil 2,600 milligram per meter square infusion, which was given for the 24 hours, day one. Leucovorin 200 milligram per meter square, day one, of salbutamol 85 milligram per meter square, day one. And this was given every 2 weeks for the next 4 weeks, a total of 8 weeks, after which resection was conducted 4 weeks after the perioperative chemotherapy, and post resection there was another 4 cycles of float, which were given on different time intervals according to the status of the patient. And this was compared to the ECF-ECX regimen in the MAGIC trial. So, on the randomization of patients, 116 patients were randomized either to ECF-ECX group or the float group, of which 354 patients in each group received perioperative chemotherapy. 19 patients in the ECF-ECX group did not proceed to surgery because 11 patients had progressed during the treatment or had died. 4 patients had worsening health condition, 3 patients opted out, and 1 had metastatic disease on the preoperative workup. 11 patients in the float group did not proceed similarly to surgery because 6 of them had progression or early death, 1 had worsening condition, 3 patients had opted out, and 1 had metastatic disease. So a total of 341 patients in the ECF-ECX group underwent surgery. I have only 314 who received radical surgery of total tumor resection. And in the float group, 345 patients underwent surgery, 336 patients received tumor surgery. Of the 314 patients in the ECF-ECX group, 200 died at the time of analysis and the end of trial, and 166 out of 330 in the float trial had died at the time of analysis. Coming to the tumor characteristics of patients which are put in the ECF-ECX and the float group, majority of the patients in the trial were gastric cancers, comprising of 44%, followed by GE junction tumors, of which C1 type 1 was only 24% in the ECF-ECX group and 23% in the float group. There were no patients with this esophageal adenocarcinoma. And the majority of the patients in both of the groups, around 80%, were T3, T4 disease and not positive disease. Coming to the outcomes of the trial, the primary outcome was initially disease-free survival, but was later changed to overall survival during the course of the study. And secondary outcomes included disease-free survival, surgical morbidity, mortality, and adverse events. Surgical outcome. So the median overall survival in the float trial was 15 months compared to the ECF-ECX group, which was 35 months. So the float regimen provided 15 months added median overall survival advantage, and this was clinically significant with a p-value of 0.012. And the overall survival at 2, 3, and 5 years was higher for the float regimen compared to the ECF-ECX group. As we can see in the graph that throughout the study period, the float regimen had at least 9% improvement of overall survival compared to the ECF-ECX group. The median disease-free survival was 13 months for the float group compared to 18 months for the ECF-ECX group, and this was also clinically statistically significant. Coming to the pathological findings of the resected specimen, it showed that float had a better pathological response and downstaging compared to the ECF-ECX group. Patients in the float group had 25% T1 disease compared to 15% in the ECF-ECX group. Similarly, more non-negative disease in the float group, 49% versus 41%. And a greater number of patients in the float group were able to undergo RO resection, 85% versus 78%. And this was clearly statistically significant with the p-values given. Pathological complete response was achieved in 7% in the ECF group and 15% in the float group, which was twice as much. And major pathological response in the float group was 37%. That means of all resected specimen, less than 10% of tumor was found in 37% of these patients. Coming to the tolerance to therapy, about 90% of patients in each group completed preoperative chemotherapy. However, when looking at the patients who started allocated postoperative chemotherapy and those who completed all cycles of chemotherapy, the percent of patients who could do that were more in the float group compared to the ECF-ECX group. That means that float therapy was at least, if not was more safe and more tolerable than compared to ECF-ECX group. And the most common reasons for discontinuation of chemotherapy were, number one, either the decrease that progressed during the follow-up or those lack of effective chemotherapy or early death. And this was more in the ECF 21% versus 13% in the float group. The second most common reason for discontinuation was patient request, which was similar in both the groups. And the third was toxicity, which was a bit higher in the ECFS6 group compared to the floor 13 versus 10%. Coming to the toxicity for both the groups was different because these are different chemotherapy regimens, different drugs. So in the trial, nausea, vomiting, thromboembolic events, anemia were more common in the ECFS6 group, while infections, neutropenia, febrile neutropenia, neuropathy, and diarrhea are more common in the float group. And the most common toxicity for both the groups was neutropenia. Coming to other post-operative outcomes, severe adverse events in terms of grade 3 and grade 4 toxicities were similar in both the groups, as well as toxic deaths, which were similar, and hospitalization for toxicity was similar. Coming to the post-operative complications in terms of morbidity and mortality were also similar in both. Post-operative morbidity in terms of post-operative complications and hospital stay and number of operations were similar. And post-operative mortality of 30 and 90 days was better, slightly better in the float compared to the ECFS6, but it was not clinically significant, and they were in accordance with the standard of in the current era. Coming into the subgroups, in all the subgroup parameters, all favored float over the ECFS6 group when looking into the stakes of the patient population, the age, the echo performance status, the location of the tumor, histology type, and lymph node involvement, whether it was a positive or negative disease, T-stage, all favor float more than this year. So to conclude that float regimen has better outcomes in terms of overall survival, disease-free survival, and it had a greater pathological response. It was well tolerated in terms of toxicity, safety, and tolerance, and it had similar morbidity and mortality compared to the standard of care at that time. And therefore, hence, we can say that the new standard of care, float had become the new standard of care for perioperative chemotherapy in patients with gastric and gastroesophageal junction adenocarcinoma. There were some limitations to this trial. First of all, the 5-year survival are an estimation because the trial was a total of 6 years, 4 years of recruitment period and 6 years of total follow-up. So 5-year survival is an estimation and can change on longer follow-up period. Those are change in primary endpoint from disease-free survival to overall survival, but I could not see this point to be this point affecting the outcome of the trial. Most of the patients in this trial did not complete post-operative chemotherapy because of various reasons which I mentioned. And the majority of the patients in these trials were gastric tumors, very few were severe type 1 and known with distal esophageal adenocarcinoma. Later in the same year, October 2019, safety and response on float trial data were published from India study, which concluded that float regimen is a better tolerated perioperative therapy in Indian patients and had higher pathological response compared to EOX and ECF regimen, which was using the MAGIC and modified MAGIC trial. Also, a recent study in June of 2024, which was published in the safety and efficacy of perioperative float in Japanese patients, as the authors mentioned in this study, that they are not aware of any previous studies on float in this particular population of patients. And they have reported this to be one of the first trials of the safety and efficacy of float in Japanese patients. And they have reported safety and efficacy of float. Adaptation of float in the ESMO guidelines and in the major guidelines. So both ESMO guidelines and NCCN guidelines have adopted float as a standard of care. So for ESMO guidelines for locally advanced disease of adenocarcinoma of the distal esophagus and gastroesophageal junction, they have given the standard of care being neoadjuvant float and neoadjuvant chemoradiotherapy. However, they have not said the preferred option, but they mentioned both are possible and have left it on institutional guidelines. While in NCCN guidelines, they have given preference to preoperative chemotherapy as the first line of choice, followed by perioperative chemotherapy in terms of float. So while analyzing this trial, some of the questions which came to my mind is that this trial majority consisted of patients with gastric adenocarcinoma and few patients with more proximal tumors. And as you know that the more proximal the tumor, the biology changes, also the prognosis is different. So can the data from this trial be extrapolated for more proximal tumors? Is it a true representation of more proximal tumors? Secondly, as you know that in some part of Asia, like Japan, China, Korea, perioperative chemotherapy has not yet become the standard of care. They would still the standard of care is adequately performed surgery followed by followed by adjuvant chemotherapy. And they have published trials which have similar results to perioperative chemotherapy. So is it that perioperative chemotherapy is a compensation for less adequately and less extensive surgery which is performed in the Western and American population compared to the Japanese, where they are very aggressive in the surgical approach? And finally, just knowing the histology of the disease is not enough. And now the king is the biology and the molecular characteristics of the tumors. And we know in gastric and gastroesophageal junction adenocarcinoma, at least 25% of the patients have well-established genetic mutations. For example, in the deficient MMR genes and microsatellite unstable tumors of gastric and gastroesophageal junction, FLOT did not provide adequate response. And in fact, most of the patients who are given in other trials which were given FLOT had either progressed or become unresectable during the perioperative chemotherapy. And after adding immunotherapy, they had regressed, they had become resectable, and they achieved greater RO resection. So does that mean that FLOT is standard of care for all 100% of patients with gastric and gastroesophageal junction adenocarcinoma? Maybe not. So I try to limit my presentation to time. And thanks for giving me an opportunity to increase my knowledge.
Thank you, Dr. Nishat. He's comprehensively covered the trial. Just a few points from my side. FLOT started off as a phase 2 trial. Initially, the first 300 patients, the results were given out as phase 3, where the efficacy, where the efficacy was checked, and the pathological complete response was in the tune of 15% versus 6%, which was significant. Regarding the patients completing the schedule, around 46% of the patients completed the schedule, which was much better than those with the MAGIC protocol or the modified MAGIC protocol. So in the MAGIC side of the trial, MAGIC arm, around 37% completed, which was similar to what was seen with the original MAGIC trial. This was a well-conducted trial, actually. There was 40% of patients had a diagnostic laparoscopy staging and a PET-CT in the pre-operative, in the pre-therapy stage. Another thing with regards to the toxicity is the use of colony stimulating factors, which was comparatively more in FLOT than in MAGIC. And if you look at the numbers, it is 21% for those in the MAGIC arm versus 34% for those in the FLOT arm. As such, another reason for the reason at least the trial members gave for the more toxicity is that the toxicity was evaluated every 2 weeks in case of FLOT, because the regime is for 2 weeks for the first 4 cycles and then 2 weeks after the surgery, versus 3 weeks in the MAGIC protocol. So I think the rest is covered well. So FLOT changed the standard of care in the perioperative group. In the perioperative chemotherapy, it became taxane based post this trial. Now we move on to the next trial.
Murugappan, there is a question from Dr. Jasmeet Singh. Can you please take that in the chat? He says that if it is a distal gastric carcinoma with gastric outlet obstruction, either we should go for direct surgery or we should have a feeding access with FJ, NJ. I would add another thing, a stent, gastroduodenal stent, if cost is not a constraint, then followed by neoadjuvant. What is your view on that?
So we look at whether the tumor is locally advanced, get the imaging done, look at the CT, whether it's infiltrating the pancreas. Also the symptomatology of the patient, whether the patient is having a bleeding tumor. If there are multiple ways you can approach this patient. If you are able to get a NJ across, I think you should do it, or a stent across, stent placed. But even a primary surgery where you directly take the patient for a resection wouldn't be wrong in this case, in case of a bleeding tumor with a gastric outlet obstruction, if you can achieve a complete resection, that is most important. In case of a bleeding tumor, maybe even a neoadjuvant therapy can also be attempted. So all four options are available. It depends on the individual. It is basically individualized.
So, students, I would like to just make one or 2 points. Neoadjuvant treatment can be given in a tumor which is technically resectable, like a T2 N0 tumor is technically resectable, but still neoadjuvant treatment is given for all its benefits. Second is tumors which are possibly unresectable with adjacent organ infiltration, where you want to take care of this locally advanced disease and make it possibly resectable. The disadvantage which you should always remember and mention when neoadjuvant treatment is being discussed is that the imaging is maybe fallacious in some cases. So some patients who are not a candidate for adjuvant therapy like T1 N0, some patients with T2 N0 may receive treatment. And second disadvantage is that if the toxicity is severe, a possibly resectable lesion may not go for resection because of severe toxicity. So these are points which you should be able to mention. Second point, which was there, which you should always remember, and when you are presenting your own data, you should make sure that you do it. In major procedures like esophagectomy, pancreaticoduodenectomy, liver resection, liver transplant, now 30-day mortality alone is not an acceptable parameter. You have to mention the 90-day mortality also. And as you saw, there was a significant difference between 30-day and 90-day mortality, because after these major procedures, patients tend to die either in the hospital or outside the hospital within 90 days also. Third point, which Nishaath did mention in his critical analysis, whether the extent of surgery decides whether you should give neoadjuvant treatment or not, especially in the resectable tumors. And the major drawback of all surgical trials is that the extent of surgery cannot be standardized. One center may not be doing as good surgery as another center, or one surgeon may not be doing as good surgery as another surgeon. And this was the problem when D2 gastrectomy came to the West, that the results in the hands of Western surgeons were not as good. So yes, these are subjective points which will never be answered in surgical trials. So thank you, Nishaath. Thank you very much. I think Murugappan, Mounica and Shikha, please bear with us, because I think it's important that we discuss each trial in great detail. So I'm sorry if we are not able to cover you in this session, which I am sure we will not be. But keep your presentation. Depending on availability of Dr. Murugappan, Dr. Anand will schedule another session with you. But please hang on and be on the program. So next is Dr. Ankit. Dr. Ankit is a surgeon from the Armed Forces, Colonel or Lieutenant Colonel?
Lieutenant Colonel, sir.
Lieutenant Colonel. He's currently doing his MCH in surgical gastroenterology at the prestigious All India Institute of Medical Sciences, New Delhi. He was also one of the first few students, and now I can call him student because he's doing MCH, to respond to my request. So Ankit, please. Mounica and Shikha, if any one of you want to take precedence over Ankit, or is it okay that you will present next time? Can you please come in? Shikha again is an armed forces person, Lieutenant Colonel. Shikha, is it all right that you present the next time?
Yes, sir. Yes, sir. No problem, sir.
Good. Mounica? Okay. Ankit, please. Ankit again is a regular student of JST, and he was also here during the Jaipur Surgical Festival. Please.
Good morning, sirs. Sir has already introduced me. So I thank you, Kapoor sir and Murugappan sir, for giving me this opportunity. So before moving on to the Neo-AGIS trial proper, I would briefly comment on these trials. Murugappan sir has already introduced these trials. So MAGIC trial compared 3 cycles of ECF before surgery and 3 cycles after surgery. And for a long time, it was a standard of care after this trial was published. This was followed by a cross trial by Van Hegel et al. Published in NEJM in 2012, which is a Dutch group. They actually compared the idea of neoadjuvant chemoradiotherapy followed by surgery versus surgery alone in potentially curable esophageal or GE junction adenocarcinomas. So they focused specifically on adenocarcinomas. It was a phase 3 trial with the primary endpoint being overall survival. In this trial, 75% cases belonged to esophageal adenocarcinoma group, and they realized that the overall survival was significantly better in the neoadjuvant chemoradiotherapy group than the surgery group. The NACRT group also had better R0 resection rates to the tune of 92%. Now in Joel Shapiro, in Lancet Oncology in 2015 published a long-term follow-up of this trial, wherein they said that they noticed improved long-term overall survival and progression-free survival in esophageal and GE junction cancer, and it was statistically significant and clinically relevant for both esophageal adenocarcinoma as well as esophageal squamous cell carcinoma. Then came the FLOT4 trial, which Dr. Nishaathussein has presented beautifully. So the FLOT4 has, again, after this trial was published, become the standard of care, included in all the international guidelines. So 4 cycles before and 4 cycles after. So with this, we come to the new ages trial. The background of trial being that adenocarcinoma of esophagus and GE junction has been gradually increasing in incidence, to which GERD and obesity are prominent contributors. Despite trials like CROSS and FLOT, they realized that there is no gold standard of care due to scarcity of high quality phase 3 trials when it comes to this particular disease. So they said that there are RCTs required to address the curative approach, potentially curative approach for this locally advanced carcinoma. So they again said that there is a trimodality therapy, there is a pre-op or perioperative chemotherapy, which have already been proven superior to surgery alone. So they set out to compare the preoperative chemoradiotherapy versus peri-op chemotherapy. The full form of this study being neoadjuvant trial in adenocarcinoma of the esophagus and esophagogastric junction international study. It was an open label randomized international phase 3 trial, which, as I said earlier, compared trimodality therapy versus peri-op chemotherapy for locally advanced adenocarcinoma of esophagus and GE junction. This trial, the time period was January 2013 to December 2020. They included biopsy proven cases of adenocarcinoma of esophagus and GE junction, which were clinically T2 to 3 and N0 to N3. And they included CVAT 1, 2, 3. I'm sure we all know the CVAT classification of GE junction tumors. Now, they specifically included the primary tumor length of up to 8 centimeter, because they had to give they expose the patient to radiotherapy. So the field has to be defined. And if there were lymph nodes in the perilesional area, so they increased the length of to around 10 centimeter. They added another 2 centimeter. So between 8 to 10 centimeter based on the presence or absence of lymphadenopathy. Patients had to be clinically ECOG 0 to 2, had to have good cardiac and pulmonary reserve. And they also set a few definitive hematological parameters. They excluded patients who had previous exposure to chemotherapy or radiotherapy, because those might have been potential confounders. Now, the study was done across 24 European centers. As I said, it compared neoadjuvant chemoradiotherapy, that is essentially the CROSS regimen, versus modified MAGIC regimen. The MAGIC trial included ECF regimen. However, the modified MAGIC regimen includes IV epirubicin. In place of IV cisplatin, they could substitute it with IV oxaliplatin. And in case of IV fluorouracil, they could substitute it with oral capecitabine. In the May of 2018, once the FLOT trial was published and everybody realized that this should now be the standard of care, they almost midway changed their regimen from modified ECF to FLOT. And so what was followed was 4 cycles of FLOT perioperatively. A 1:1 randomization was used, and they restaged the patients 4 to 8 weeks post neoadjuvant treatment with either CECT or PET-CT. Endoscopic response was also assessed before surgery, which they defined as complete, partial, that is more than 50% tumor reduction, and any reduction less than 50% tumor volume was defined as no response. Surgery was done 3 to 10 weeks after last treatment, and the recurrence monitoring was supposed to be done with CECT or PET-CT and endoscopy at 1, 2, and 3 years from randomization. If a recurrence was suspected, PET-CT was done, of the results of which, if equivocal, a cytological or histopathological confirmation was sought. Now, this trial had some unique elements. It addressed a unique population of patients with adenocarcinoma of esophagus and GE junction. They had standardized the pre-treatment TNM staging with FTG PET CECT, radiotherapy quality assurance, which they ensured, and they reported the complications strictly along to the ECCG guidelines. And obviously, the trial was amended after the publication of FLOT. to reflect the changes in standard of care. The primary endpoint was kept to be overall survival. It was defined from date of randomization to death from any cause. And those alive at the time of termination of trial were censored at the time of last assessment. Censoring refers to a situation where the exact timing of an event is not known. In the context of this trial, it was because the trial was stopped prematurely in between without complete accrual. The secondary endpoints were disease-free survival, which was defined as randomization to first event, either local recurrence, distal recurrence, progression, or death. Then site of treatment failure, if at all recurrence occurred. Post-surgery 90-day complications, as Kapoor sir had just pointed out. Toxicity, pathological complete response, and major pathological response. Margin-free resection, and they also included health-related quality of life using QLQ C30 3.0 questionnaire. So coming to the statistical analysis, I have tried to keep it as basic as possible because I know most of us surgeons struggle with statistics and I'm one of them. So the initial trial design was the trial was powered 80% power to detect 3-year increase in the overall survival of 15% with the neoadjuvant chemoradiotherapy. The trial modality being predicted superior. So this was a superiority trial to peri-op chemotherapy, and the total number of patients they had to enroll was 366. This was then again modified in 2014 to increase another 10% increase, requiring 594 patients to achieve 80% power. So the number of patients to be recruited increased from 366 to 594. And then, as told before, in the May of 2018, the protocol was amended from modified MAGIC to FLOT4. And then this design was changed to non-inferiority. So this is a major step in a trial where you have set out to prove superiority, but then realizing the details, the data presented by FLOT4 trial, they have changed the design to non-inferiority, stating that the chemoradiotherapy is non-inferior to this FLOT4 regimen. The first futility analysis was done in December 2018, till which time there were 76 deaths and an anticipated 3-year survival of 57 for chemotherapy and 52% for trimodality therapy. Again, they revised the enrollment target to 540 patients. The second analysis was done 2 years later in December 2020, when there were about 143 deaths, 50% of expected deaths, and only 377 patients could be enrolled till that time. So they after the third revision, they had set to enroll around 540 patients, where, however, they could only enroll 377 patients. And they could not establish futility and non-inferiority. And the analysis of the data presented at that particular point of time showed that there were similar survival rates from both interim analysis, and these rates were unlikely to change if the trial was continued or a long-term follow-up was done. Hence, considering all these factors, the trial was closed premature. Coming to baseline characteristics, so there were total of 184 patients in the perioperative chemotherapy group and 178 in the trimodality group. All the baseline characteristics were comparable in both the groups, including tumor location, TNM staging, and procedures performed. There were no statistically significant difference in both the groups. This is the trial profile. In the preoperative chemotherapy group, 184 patients were enrolled, 162 had surgery, and 184 were included in intention to treat analysis. In the chemoradiotherapy group, the trimodality group, 178 patients were started and included in intention to treat analysis. There were 95 deaths in the perioperative chemotherapy group, and in the trimodality group, there were 91 deaths. So coming to the results, few of these I have told earlier. The FLOT regimen, after they changed it in May 2018 from MAGIC to FLOT, comprised of 15% of perioperative chemotherapy group. So in the perioperative chemotherapy group, 85% of patients still received the modified MAGIC protocol. In this group, 166 patients completed all pre-op cycles. That amounts to 90% of these patients. 108 completed at least one post-op cycle. That is 59%, and 75 patients, numerically, that comes to around 41%, completed the entire protocol. Whereas in the trimodality group, 154 completed the full treatment protocol. That is a large number when you compare these two arms. And 177 completed the entire radiotherapy protocol. There were a total of around 165 serious adverse events, which were comparable between the two groups. Grade 3 neutropenia being the commonest adverse event, and a minimum of 18 months follow-up was done after the last patient was recruited. As I told earlier, the final analysis of the trial was done on March 2nd, 23. A median follow-up of 38.8 months was there, between an IQR range of 16.3 months to 55.5 months, the longest follow-up, and that's I've already mentioned. Coming to the primary objective of the study, overall survival, both the arms did not actually differ in overall survival. The median overall survival was 48 months in the perioperative chemotherapy group and 49.2 months in the trimodality group, which is numerically and equal and statistically not significant. The 1 year survival was 84% in perioperative group, whereas 87% in trimodality group, which at 3 years was 55% in the perioperative group and 57% in the trimodality group. Again, not statistically significant. Coming to secondary objectives, the disease-free survival. The median disease-free survival was 32.4 months in the perioperative chemotherapy group and 24 months in the trimodality group. However, this was also not statistically significant, with the p-value being 0.41. Coming to further wider analysis of both the groups, they analyzed response, regression, and recurrence, and they realized that now this is a striking feature of this trial, the results of which I'll be communicating after this slide. They realized that trimodality performed overall better, with a statistically significant difference in the pathological complete response, major pathological response, which they said was combining tumor regression grade 1 and 2, grade 1 being complete pathological response and grade 2 being predominant fibrosis with scattered tumor cells. So these two were seen significantly more in the perioperative chemoradiotherapy group than the periop chemo group alone. The chemoradio group also had better lower poor response, that is the lesser number of TRG grade 4 and 5, better negative margins, higher lymph node yields, and higher partial responses. Now, when we look at this table, we think that obviously the trimodality therapy should be, if it is showing us all these results, it should be statistically significant. However, these higher pathological complete responses did not translate into statistically significant survival benefit, including the quality of life. Adverse events I have already highlighted previously. Diarrhea, odynophagia, neutropenia, which is obviously very significant, peripheral neuropathy, and alopecia were some of the few. So to conclude, this trial showed that 3-year median follow-up with there was no significant 3-year overall survival difference. It was 57% in trimodality versus 55% in periop chemotherapy. And the median survival was 49.2 months, percentage-wise 49.2 versus 48% at the closure of trial. Both these regimens had similar pattern of treatment failure, post-op major morbidity, mortality, and non-inferiority was not established at trial closure. 2 more trials were done after this, which are POET and NEORES trials, which had similar results, showing that higher pathological complete response did not actually translate into survival benefit. So the final conclusion of this trial, likely hypothesis that they gave, and which brings us to the question that Dr. Nishaathussein raised, that modern era radical surgery works as an equalizer, which limits any potential added loco-regional benefit of the trimodality therapy. Whatever benefit radiotherapy offers is all neutralized or equalized by the radicality of modern era surgery. That's it, sir. I'm done, sir. Sir, Murugappan, sir, you're muted.
Sorry, yeah. So just a small change. POET and NEORES were trials which were phase 2 trials which were done before this trial. So
yes, sir. Sorry, sir.
in the topic of optimal neoadjuvant therapy before surgery, there were three studies before this, two of which the major ones were the POET and the NeoResus. POET was from the German group. NeoResus was from the Swedish group. NeoResus, they looked at pathological complete response as a surrogate marker for overall survival. They still didn't find any improvement in survival with the neoadjuvant radiotherapy. Though there was more pathological complete response with radiotherapy. Similarly, with POET, even though there was a survival benefit, it was not statistically significant. Another thing would be, I just saw someone in the group asking about the ESOPEC trial, which is a trial which looked at FLOT versus cross. The FLOT aspect of neoages was just 15%, so they couldn't do a subgroup analysis to see whether FLOT actually benefited these patients better than MAGIC or modified MAGIC. ESOPEC has come out with its abstract recently, and it did show that there was a better pathological complete response to the tune of 19% more in preoperative versus preoperative chemotherapy, with respect to chemoradiotherapy. The 3-year survival was 57% versus 50%, and the median overall survival was 66 months to 37 months, all favoring FLOT more than cross. We need to wait for the expanded results of this trial to further go on to this. But they've said that FLOT is better than cross. This was done in Germany. We've just I've received only their abstract. The other things which were slightly unclear with this trial is, as I've already mentioned, there were more pathological complete response, more R0 resections. Despite that, there was no survival benefit in these patients with radiotherapy. Another point would be, once someone adds a radiotherapy, is expecting a better local response. And once a systemic therapy like chemotherapy is given, people will expect a better systemic response. So when you looked at the sites of treatment failure in this trial, even though there were lesser number of liver and lung recurrences in chemotherapy patients, it somehow didn't lead to a better, lesser rate of a systemic failure. However, if you see that the rates of systemic failure are in the tunes of 21% in chemotherapy was 23% in chemoradiotherapy. So the effect of chemotherapy is still unclear in this trial. Another point I would like to make is, if you look at the forest plots that they've put up, there is some suggestion to show that for a T3 tumor and node negative tumor, radiotherapy seems to do better. Whereas if you can just go to the forest plots, you have it.
Yes, sir.
So while Ankit is coming, just a few points again. With many a time you are asked in the exam.
This is the forest plot, sir.
Yes, now we can see.
Sorry, sir. When you look at the forest plots, there's a slight benefit of favoring of radiotherapy in patients with T2 disease and node negative disease, clinical versus chemoradiotherapy in node positive disease, that is clinical node positive disease and T2 disease, or in patients who have achieved complete response after the neoadjuvant therapy. The chemotherapies seem to have done better. So this is what I just wanted to point out. Another thing with this trial was the pathological complete response in the cross arm was in the tune of 12%. This was comparatively lesser compared to the cross original study, which had a pathological complete response in the tune of 23%. So these are the points that I wanted to make.
Does this, sorry to interrupt, does this have something to do with the population or, molecular characteristic of the tumor, which actually have not been included in this trial? Could this have something to do with that?
It could be possible. There are other multiple variable factors that could have led to this. But as such, the radiation planning, everything was up to the standard in this
Yes.
trial, and it was a well-conducted trial actually. So the ESOPEC, which is flot versus cross, would give us more idea, and then we can probably decide on which is the better therapy. But as of now, we should continue clinical equipoise with respect to deciding what should be the optimal therapy in the neoadjuvant setting in these patients.
Just a few points for the students. So very often you are asked in the exam, is the length of the esophageal lesion important? From this trial, it becomes obvious that it becomes important if you are planning to give radiation, because that would decide what area is to be radiated. So you can mention that point. And very important point highlighted, that response or recurrence may not translate into improvement in survival. Although I would presume that it should have affected the disease-free survival. If there is better response, pathological, then it should have resulted in better disease-free survival, if not overall survival. Second point, which already Dr. Murugappan made, that surgery and radiotherapy are loco-regional methods of treatment. So they would affect local recurrence or regional recurrence in the lymph nodes, whereas chemotherapy takes care of the micrometastasis and distant metastasis in future. One point which maybe Murugappan in the next session we can discuss, and the other two presenting students can also note this, that have these trials done an analysis of a sub-analysis or a secondary analysis of those patients who completed the entire protocol. See, a significant number of patients could not complete the entire protocol. So is there a difference between those who completed versus those who could not, for whatever reason, complete the treatment? So that is another point which has to be kept in mind when analyzing these trials. So thank you, Nishaath and Ankit, for excellent summary of the trials. And sorry, Mounica and Deepshika, Dr. Anand will arrange another session depending on the availability of Dr. Murugappan, and we will definitely have your presentations also. Thank you very much.
Thank you, sir.
Thank you, sir.
All the students can send me a mail, pkkapoor.india@gmail.com. And also, I would say that if there has not been a good recent review on the new trials, although Dr. Murugappan has covered most of these trials, but I think some trials probably have come after that. So you can go through that article, and if four of you together want to write a review, you can join hands under the guidance of Dr. Murugappan and write a fresh review or a kind of a leading article as to what is the current status of treatment of squamous cell carcinoma esophagus, esophageal adenocarcinoma, GE junction, and CS stomach, to give a clear guideline to the students and practicing surgeons. So thank you all. Thank you very much.
Thank you, sir. Thank you.
Thank you.
Thank you.